Thank you very much for inviting me. This is really an honor and a pleasure. And I'm going to talk today about orofacial pain, which is unfortunately a topic that sometimes is not very well recognized or understood. So my name is Alberto. I'm a dentist. I graduated in Valencia in Spain. After that, I did my specialty training in University of Minnesota, where I also did a master. And now I'm currently doing a PhD in experimental medicine in McGill, basically trying to look different ways to improve orofacial pain and different associated outcomes. So first things first, orofacial pain is basically defined as pain localized in the face and or oral structures. It has also been defined by the International Headache Society as pain below the orbito-meatal line anterior to the pinnae and above the neck. And sometimes different definitions also include the forehead. Other practical definition is basically associated with the distribution of the trigeminal nerve. So basically the second and third branch, it will be considered orofacial pain. And the first branch, it will be considered a headache. And this definition has actually practical implications because sometimes orofacial pain will be treated by the dentist and headache by physicians. However, there is a problem with this, and is that given the special characteristics of the trigeminal nerve and the way it enters into the brain, there are a lot of times that pain can be referred from one area to the other, and in that way, pain coming from originated in the dental structures or in the teeth can go to other structures like muscles or even behind the eye. And to the contrary, pain originated in other structures can go to the teeth. So it can suppose like a very good or a very big diagnostic challenge. Because of this, unfortunately, patients sometimes can bounce between physicians and dentists because dentists can see that the dental structures are fine and then refer them to the physician and vice versa. So some of them, unfortunately, they receive inadequate care. So given their knowledge about teeth and their relationship with other facial structures, and also this constant overlap that I mentioned before, dentists may be in an optimal position to manage orofacial pain disorders. However, it has been reported in different surveys and studies across different countries that general dentists, recent graduates, and dental students had a overall low level of competence and confidence in the management and also dental curricula in orofacial pain. This is important and quite unfortunate because the prevalence of orofacial pain is actually high. It has been reported in the United States, United Kingdom, and Hong Kong that the prevalence can go around 22 to 26%, also including dental pain. And also another study in Brazil suggested that it can go as high as 56%, including also headache. So orofacial pain, especially when chronic, can have important consequences. It can be very debilitating. It can have a high impact on physical and psychological health, and also impairs significantly social function because with the face, we are using the face all the time for different things, and we are using the mouth for very vital functions like eating or talking. There are different classifications of orofacial pain based on different locations and mechanisms. Very recently, an international classification was developed based on different or considering different pain expert groups and disciplines. So my goal today is actually not go in detail about in this classification about each of these disorders, but actually just give a general overview of the most common orofacial pain disorders or types, so you can have a broad understanding. So for the sake of this presentation, I will be simplifying a lot the orofacial pain types. Therefore, we can basically divide them in pain that is origin from dental structures, also called odontogenic pain, originated in muscle, bones, and in the temporomandibular joints, also called musculoskeletal, coming from the nerves, called neuropathic, blood vessels, also called neurovascular, or from an unknown cause or idiopathic. Very importantly, all of these structures, as I mentioned before, can be presented as tooth pain. So it's very challenging, and they can be occurring at the same time. The presence of one doesn't exclude the other, so we can have two of these orofacial pain types. In fact, it's not uncommon to have those. And it can be very, very challenging in that case to discern the cause of pain. So talking about the most common orofacial pain is simplistically speaking, tooth pain. So it's inflammatory in nature and affect like the different structures of the tooth, also including periodontal structures and the gingiva. It also includes osseous and structures and glandular tissues. And dentists are actually very highly skillful in identifying these disorders and in eliminating the cause of the pain. So basically, if there is a cavity caused by an infection, dentists can easily see that and remove it, and then the pain is gone. So it's quite straightforward. However, this is not the same for other types of pain, where we can actually not see any identifiable cause. We don't see an infection, so we have to think and basically try to see different pain characteristics to see what could be the diagnosis and how can we treat that in consequence. In that way, we will have to look at different parameters, like kind of like a small detective, to check like the location of the pain, the onset, when it started, the quality, the intensity, the frequency, how many times per day, for example, how long does it last, if it's aggravated by something specific, if there is some specific also alleviating factors or other associated symptoms. And all these things will actually give us some clues or like ideas about what could be the diagnosis. So the most common orofacial pain disorder besides dental pain is temporomandibular disorders. Perhaps you have heard about it. It's also called TMD. And this term is used to describe different mechanical and painful conditions that affect the temporomandibular joint, which is in front of your ears, basically, and the muscles of mastications and supporting structures. It affects around 5 to 12% of the general population, and it affects more females than males in a ratio of 2 to 1, or sometimes it has been reported 3 to 1. Very simplistically speaking, we can divide painful TMD into muscular, if the origin of the pain is in the muscles, also called myofascial pain or myalgia, or articular, also called arthralgia, if the pain actually originates in the temporomandibular joint. And what we are seeing is like they actually frequently occur together. Patients with TMD, they have both muscular and articular. So fortunately, there is one of the few orofacial pain disorders that has a validated diagnostic criteria, which basically consists in palpate ask the patient to do some movements with the jaw and palpate some different muscles of mastication, basically the temporalis and the masseter, for example, and the joint. And we ask the patient if that is painful, if the pain is referred to some other structure, and very importantly, and this is kind of like the key, if this is the pain that they usually feel, or if this is their familiar pain, or in other words, if the pain can be duplicated with palpation. And this has a very good sensitivity and especially very, very high, almost perfect specificity. So going more into TMD muscular or myofascial pain, it can be located in the angle of the mandible, cheek, or temples. The onset is very variable, but it can frequently occur after dentist appointments, unfortunately. Also, sometimes when the patients wake up in the morning, and also it can occur after periods of high stress. The quality is more like a dull, achy, boring feeling. Sometimes it's described like as a fatigue or tension. The intensity is mild to moderate usually, and the frequency is quite variable. It can be from one day or 1 week the patient is without pain, and then the next week the patient has pain, or it can be actually continuous with fluctuations or peaks or wax and wanes. The duration is minutes to continuous. It's usually aggravated by jaw function, moving the jaw, for example, for talking or for eating. It improves, or it can improve actually with cold, heat, or analgesic medications, over-the-counter Tylenol or ibuprofen. And sometimes it is associated with changes in the way the teeth fit together, or malocclusion, and also with limited mouth opening. If we go more to articular, TMD is more easily located in a way because it's mostly located in the preauricular area. The onset is more acute, perhaps after like a big, after joining or biting something hard, or even after a trauma. And here is important, like the quality is usually different. It's more like a sharp feeling that will help us to differentiate it a little bit from the muscular pain. The rest is relatively similar. Perhaps it lasts this sharp feeling, it lasts less seconds, and then it can linger. It is also aggravated by jaw function. And then besides, in addition to the malocclusion and limited mouth opening, sometimes there is also like some swelling that could be caused by some inflammation of the retrodiscal tissues or the capsule involved in the joint, basically. The management of TMD, I'm gonna reinforce this because in not so chronic cases, self-care, even though it looks like too simple, is actually one of the most important things to treat this disorder. This basically is based on avoidance of aggravating and contributory factors like chewing gum, clenching the teeth, or even like holding tight the jaw. And this is extremely common, especially when we are like focused or doing different tasks. It's also aggravated by, we also like can recommend to avoid the wide jaw opening. And sometimes it can be aggravated also by sleep bruxism or night grinding, although this is a little bit controversial right now. There is not a lot of literature actually supporting this. And this can be controlled relatively with a mouth guard or an oral device that can be done by the dentist. Also, physical therapy to reduce pain, gain function, and improve posture and coordination is very useful. Health psychology to recognize dysfunctional beliefs, to reduce stressors, and also for the recognition of behaviors like, for example, clenching. And mouth guards that can be done by the dentist, although for pain itself, it has been shown that they are not greatly superior than placebo, but nevertheless, they are helpful. We can also prescribe short-term medications, for example, muscle relaxants, sometimes like some antidepressants with pain properties, or sometimes so simple as like Tylenol or ibuprofen, it may help. And in some more severe cases, especially when the joint is involved and there are more mechanical problems, surgery is also recommended. If we go to neuropathic pain, obviously we have to talk about trigeminal neuralgia, which is the main one I'm going to discuss today. You should know that there are other ones like postherpetic neuralgia, post-traumatic pain, or neuritis that are less common. And they are there. I'm not going to mention them today, but I want you to know. Trigeminal neuralgia is basically the most well-known, unfortunately, because it's so painful and it has so many consequences in the in the quality of life of the patient. That is the most well-known episodic neuropathic pain condition in the face. It is estimated to affect 100 out of 100,000 individuals. And the most common subdivision include, you can categorize trigeminal neuralgia as classical when there is a compression of the cerebrovascular superior cerebral artery that can cause some demineralization of the nerve. Basically, the nerve is peeled in a way, if you think about it like a cable. Or it can be also secondary to other diseases, like brain tumors, or also multiple sclerosis, or something that is in close contact with the nerve and is affecting it. The location is actually most common in the mandibular and maxillar branch of the trigeminal nerve. Sometimes it also affects the first branch. Is usually unilateral, and this is important because it may help us to differentiate it from TMD, for example, that sometimes is more like it can be bilateral. And when the pain is bilateral and we think that it can be trigeminal neuralgia, we actually have to be suspicious about other more ominous underlying condition like multiple sclerosis. Here, the characteristic feature about this neuralgia is like electric, sharp, shooting, stabbing pain, very high intensity that occurs like very briefly and occurs several times per day, and it can be aggravated just by light touch of the lip, for example, by talking, chewing. Sometimes it can be associated with spasms in the face. It is usually not accompanied by autonomic symptoms, which would be like a redness or this feeling for the patient of puffiness, or like runny nose or even tearing. And this will help us to differentiate from other disorders. And also it can wake up from sleep. It is also commonly assumed that trigeminal neuralgia usually doesn't wake up the patient, but actually there are reports that it can wake up the patient because of some movement of the jaw or something, or even spontaneous. For the treatment of trigeminal neuralgia, the first line is based on medications, anticonvulsants, basically to calm down the nerve, like for example, carbamazepine or carbamazepine, but they are frequently associated with side effects, and managing the patients with these medications is not very easy. The pain tends to be like refractory to this. We need to increase the dose. More side effects occur. We have to do like several like blood tests to check like the levels of sodium and potassium, among others, are fine, or different like serum factors. And yeah, it's not so easy. Before this, actually, we need to do a brain MRI to rule out that it's not secondary to another cause. And when we see like it is primary, then we could start like the treatment with pharmacology. There are other surgical options like microvascular decompression, especially if we have seen in the MRI that the blood vessel that I mentioned before is very close to the trigeminal nerve ganglion. And there are also new other alternatives that have been shown benefits, but they are still quite experimental, like transcranial magnetic stimulation, that actually I will talk a little bit more later about it. And even though all these treatments, unfortunately, the pain can be recurrent. Going to neurovascular pains, probably the most common known is migraine, but there are other ones like trigeminal autonomic cephalalgias. These are the three most well-known: cluster headache, hemicrania, and short-lasting unilateral neuralgiform attacks, also called SUNT or SUNA. Depends if they are more associated with more autonomic symptoms or less. So migraine is also a quite prevalent condition, as you probably know, that affects more females. And it can be subdivided in migraine with aura, which is like about like 20% of the patients with migraine, which are some neurological symptoms associated with vision or with other senses, like spotting of bright lights or different smells, for instance, or reduce of the scope of vision, and also migraine without aura. Migraine is actually the most common location is the first branch of the trigeminal nerve, but actually, and this is important, it can also present on the other branches. So actually, it can be presented as a tooth pain, for example. So this is quite relevant because the quality of the pain is throbbing, which is very similar to a normal toothache. The intensity is moderate to high, and the frequency and duration, it can resemble to some episodes related or like toothaches, basically. So this is very important for the differential diagnosis because sometimes what we think it is a toothache is actually not a toothache, and it can be a migraine, although it's very uncommon, but we need to know it. Triggers, it can be alcohol, wine, cheese, poor sleep, or exercise, or some bright lights, as you probably are aware. Alleviating factors include basically the avoidance of triggers, some analgesic medications, and go to other room. And other associated symptoms are the presence of, as I mentioned before, autonomic symptoms like redness or like in the eye or in the face. And obviously the aura, it can give us an important clue of what's going on. For the management, there are two types in a way. There is one more like when you are having the migraine, abortive medication like Tylenol or ibuprofen, triptans or ergotamines, but we have to be careful with those because actually after 2 weeks or 3 weeks of frequently taking Tylenol or ibuprofen, this can cause a rebound headache, where actually the cause of the headache, or at least part of it, is coming from this medication overuse. So it's important not to abuse those. And then to prevent the attacks, especially when it's more like chronic, we can use other medications more related to blood pressure, like beta blockers, verapamil, other anticonvulsants like topiramate, or even we can use Botox, which basically will reduce the peripheral input of some of the muscles or sensory nerves that can have in migraine. And there is also this protocol involving like 32 points, perhaps you have heard about it, for Botox to treat migraines. Very, very, very importantly, same as with TMD, avoidance of triggers is critical, and change of lifestyle for this to avoid triggers. And also sometimes complementary and alternative medicine like acupuncture or relaxation, it may be helpful in this disorder and basically in the other ones. Regarding the trigeminal autonomic cephalalgias, I'm not going to go into detail for all of them, but I just want you to realize in this case how important it is to look the duration of the episodes and the average of pain episodes per day, because sometimes this is what it will differentiate between them or between other disorders, like for example migraine. Here you have a very simplistic comparison. It's also like I also added trigeminal neuralgia for reference purposes, and you can see like cluster headache, for example, in the first panel, it lasts longer, and then there are less episodes per day. And SUNC and SHONA, for example, is very short, very similar to trigeminal neuralgia, and there are more episodes per day. Sometimes it's very hard to differentiate between them, and what it is key to differentiate it with trigeminal neuralgia, it would be the presence of autonomic symptoms, for example. For cluster headache, the most common treatment or one very useful treatment with high efficacy is oxygen inhalation. As you can imagine, this is not super practical in the clinic, so it's also treated with triptans, similar than migraine, or with other medications like corticosteroids or topiramate. For hemicrania, interestingly, there is this medication which is an NSAID, very similar to ibuprofen, called indomethacin, but for some reason that we still don't understand, this works very well for this specific disorder, and in a high percentage of the cases, it will help. For SUNC and SHONA, the treatment is very similar to trigeminal neuralgia, involving anticonvulsants like carbamazepine or gabapentinoids. Idiopathic pain, pain from unknown cause, we have two main disorders: burning mouth syndrome and persistent idiopathic dentoalveolar pain, also known as atypical odontalgia or phantom tooth pain. Regarding burning mouth syndrome, is basically defined as pain in the oral structures like inside the mouth or the tongue, lips or mucosa, and the rest, everything looks normal. That's why it's idiopathic. Basically, it's mostly found in older people, more in female than males, and especially in postmenopausal female. It can be primary, so it's not secondary to another cause that we can see, or it can be secondary as a result of other diseases like diabetes, some nutritional deficiencies, or more related to alterations in the saliva flow. It has been also related to candida infection, to lichen planus, to some medications. This is actually frequent, and to autoimmune diseases like Sjogren syndrome. For management, we can use some saliva replacement products or some saliva stimulating products, so the patient has like more saliva flow, oral rinses, or lidocaine also. Clonazepam, it has been shown to work quite well, and also applied topically. So sometimes we ask the patient to switch the pill but spit it. So it's not, we avoid as much as possible the systemic effects of the clonazepam, which are important because sometimes they involve more like misuse behaviors. Certain antidepressants have been also shown to be useful in burning mouth syndrome. Cognitive behavioral therapy to address anxiety and depression and cope with chronic pain, and lifestyle changes like avoiding spicy food, alcohol, tobacco, some liquids, acidic food, coffee or mint, or these type of things. Going to persistent idiopathic dental alveolar pain, basically this is similar to burning mouth. This is pain located in a tooth or like in surrounding structures, but there's nothing wrong that we could see visually or with x-rays. So this can be in close relationship to a causal event like a dental treatment, but there are also reports of cases that are not necessarily related to this. We are seeing now with recent research that the prevalence is actually not as high as originally thought. So around 0.6 or 1.2% of people receiving a root canal treatment. And the range of pain is very variable, but usually is relatively low, and it doesn't. Recent reports have shown that in the long term, the impact in quality of life is not as thought as was originally thought. In this specific disorder, education, just explaining the patient what's going on, what's the cause of the pain, or in this case, what's not the cause of the pain. They need to know that the tooth, in this case, are not contributing and are fine. Also, if this is not enough, topical analgesic creams can be also prescribed. If not, we will go to systemic medications like tricyclic antidepressants or gabapentinoids. And lately, it has become also popular the use of the intraoral use of Botox, which also has some analgesic properties because of the inhibition of some neurotransmitters. Probably you have heard the expression pain attracts more pain, and this is actually true in orofacial pain conditions too. They are frequently comorbid to each other. Temporomandibular disorders have been associated with burning mouth syndrome, with persistent dental alveolar pain, and also with trigeminal neuralgia. And also importantly, it can also be comorbid to other chronic pain conditions in other areas like fibromyalgia or irritable bowel syndrome. And it is actually considered temporomandibular disorders one of the many chronic overlapping pain conditions, which are conditions with not very well understood cause that share different characteristics. And these include, besides TMD, it can include migraines and tension-type headache, and also chronic fatigue syndrome, fibromyalgia, and vulvodynia. And this is thought to be, or one potential explanation is impairment in the pain modulation's ability of the body. In a way, we will the system that is in charge in a way of feeling pain is increased, and the system that is in charge of inhibit pain is also impaired and affected. So there is a disbalance here in one and the other. Orofacial pain disorders can also be or a cause or be associated with other important psychological factors like anxiety, as same as other chronic pain conditions, catastrophizing, depression, or somatization, and also with social factors like access to medical care, stigma, and support from family and friends. But there is another important factor that is frequently not so well understood or sometimes is ignored, which is sleep, because actually 80% of patients with chronic pain report sleep problems. This is also true in orofacial pain, where almost 40% of the participants have reported in an orofacial pain clinic to present insomnia. And an important systematic review of meta-analysis showed that 44% of patients with chronic pain will show sleep disturbances when measured with polysomnography, which is the gold standard for measuring sleep disorders, being insomnia especially and sleep apnea the most common diagnosis. And also patients with chronic pain have shown to have impaired different sleep characteristics in comparison with controls, like sleep onset latency, they take longer to fall asleep, sleep efficiency, they are more time in bed without sleeping, time awake after sleep onset, and also number of awakenings. Sleep and pain, the relationship between both, it was thought to be a bidirectional circular relationship, with a night of poor sleep can increase pain in the next day, and pain can precede a night of poor sleep, although later research is showing that it seems to be more towards the direction of sleep causing or predisposing to more pain. Regarding orofacial pain, there is like this big study in temporomandibular disorders called OPERA study, looking for risk and prognostic factors of TMD, and it has shown that individuals with sleep apnea symptoms are around 1.7 to 3 times more likely to develop painful TMD, that individuals with poor sleep quality at baseline are also more likely, 1.32 times, to develop TMD, and that sleep quality deterioration actually precedes the onset of painful TMD. There is also probably the largest study using polysomnography in temporomandibular disorders, which involves 124 women and 46 controls, show that TMD patients show a higher percentage of stage N1, which is lighter sleep, and a higher index of respiratory effort-related arousals. Basically, they have more arousability, or it's easier to wake them up. But it's not only in TMD. Sleep has also been associated with other orofacial pains, like migraine is a well-known trigger, tension-type headache. There are other headache disorders that actually only occur or are more frequently happening during sleep, like cluster headache or hypnic headache. And also it has been associated with other neuropathic pains or idiopathic pains like trigeminal neuralgia, post-herpetic neuralgia, and burning mouth syndrome. So given all these comorbidities or conditions associated with orofacial pain and sleep, an interdisciplinary approach where different healthcare professionals combine efforts for a more personalized and holistic approach would be ideal for a more personalized management. Indeed, one of the papers I cited before about the classification highlighted that multimodal approaches are needed to increase the therapeutic potential of the interventions that we do for orofacial pain. In other way, so we need to account for all the other comorbidities to see if with the treatments we can also not only manage orofacial pain, but also we can affect the rest of the conditions in that way. For example, like some medications can be used for improving pain and also improving sleep, but also for improving or affecting differently other comorbid conditions like bruxism or restless leg syndrome or depression or anxiety. In that way, for example, gabapentinoids, which are also known to have anxiety properties, could be given in patients with sleep and pain and comorbid anxiety, but importantly, this has to be done inside a multidisciplinary treatment and this holistic approach. Very importantly, we also have to consider to not aggravate the other comorbid disorders. For example, it has been shown that opioids, which as you know are frequently given for pain, or even gabapentinoids, they can aggravate sleep apnea. So we have to be careful and consider the whole patient when prescribing these medications. Moreover, it is also possible that different behavioral, genetic, and physiological characteristics or vulnerabilities could be used to recognize different subtypes of this comorbidity between sleep and pain. And in that way, we could see like which disorder may be underlying this relationship or is predominant, and which mechanisms could be associated with that particular disorder. And in that way, we could better target the treatment intervention based on those mechanisms. We could use like, for example, like physical therapy, if pain modulation is affected, or cognitive behavioral therapy, if the pain is more driven by psychological factors, etc. Importantly, this approach could be refined with the use of machine learning, deep big data analysis, and also artificial intelligence algorithms based on different parameters, sociodemographic, as I mentioned before, but also related with brain imaging or physiological testing. So we could see basically develop a signature of the patient, and according with that signature, target and even develop new treatments for that specific person. Finally, I'm going to talk about transcranial magnetic stimulation, as I mentioned before, that can be used also to assess cortical excitability and then improve that signature that I was talking about before. But it can actually be used to treat different disorders. Basically, this is a non-invasive and quite safe neurostimulation technique that can depolarize neurons and stimulate different areas of the brain. And depending on the protocol, it can have inhibitory or excitatory actions. It has been used that it has been shown, that it can be actually helpful in different chronic pain disorders by enhancing pain inhibition when the motor cortex is stimulated, because it has been shown that these magnetic pulses or the depolarization of the neurons can actually travel to distant areas in a way and stimulate areas that are more related to pain modulation, like periaqueductal gray substance, the insula, etc., involving different neurotransmitter networks that are associated with pain, like opioidergic, GABAergic, or different other pathways. It has been shown that only one session can have positive effects, but the longer you apply it, the more durable effects and more intense effects in a way you can get. And it has been shown that the beneficial effects can last up to 1 month. There are some guidelines that have been developed by European experts regarding the use of TMS for pain. There's strong evidence showing benefits in neuropathic pain, a little bit less in musculoskeletal pain, but more research is needed. There is also some evidence that is useful in orofacial pain disorders. And it's important also to know that a recent Cochrane systematic review highlighted that there is a high heterogeneity in methodologies, so they are very different and therefore not so easily comparable, and that the effect size are small especially in comparison to sham treatment or placebo in a way. So we also have to be aware of that, and that large and high quality trials are needed to better discern the effects of TMS. Moreover, our group published very recently a systematic review also showing that TMS can be helpful to manage certain sleep disorders, especially sleep quality in different neurological and neuropsychiatric conditions. And why not stimulate both areas? It can be because for the sleep stimulation, it has been shown that stimulating the left dorsolateral prefrontal cortex, it may be more helpful. So it is possible to develop dual action stimulation treatments in alternative sessions or even in the same sessions that could involve both the left dorsolateral prefrontal cortex and the motor cortex to target more comprehensively the sleep and pain interactions. I'm not going to go in detail about all of them, but I want you to be aware that there are other non-invasive brain stimulation techniques based on electrical currents or in noise, like transcranial direct current stimulation or transcranial alternative current stimulation, that have been also shown to treat effectively pain or sleep, but evidence is like not as high as there is not as overwhelming or not overwhelming, but as high or is not accumulating as much as with TMS. Finally, I would like to remark that, in my opinion, the main avenue to improve patient care and orofacial pain and to reduce the burden that is associated with these conditions is to improve education, especially among dentists, who, as I was saying before, will have a very important role in managing these conditions. So general dentists, educators, orofacial pain experts, researchers, importantly, patients whose opinion and input is very highly appreciated and can give us another perspective that perhaps we are not considering, and also policymakers need to combine efforts to overcome many of the different barriers that are in place right now for orofacial pain education, like for example the lack of recognition of the specialty, to improve basically this general education in dental school for general dentists, also in postgraduate levels for orofacial pain specialists, but also for other specialties like prosthodontists or endodontists, and also to improve continual dental education. For example, in the US, right now, it has been recognized orofacial pain as a specialty, so this is very good, and hopefully this is followed or mirrored by other countries like Canada, and this can help to increase expertise, it can help to increase knowledge, and especially to help that these patients that sometimes bounce between specialties get a proper treatment. So I think this is it. I think I'm on time. So thank you very much. Again, it was a great opportunity. I will be very happy to reply any question that you may have. Thank you.
Thank you, Alberto. That was a fantastic and really in-depth discussion. We really appreciate having you here today. So yes, we will move on to the question and answer period. And just in case anyone isn't already aware, there is a button at the bottom of your screen that says Q&A, and you can post any of your questions there. So I'll get started with the first one that we received. Somebody said that first that they're so pleased that you're offering a webinar for orofacial pain. And then their question is that they often see in some patients a personality type of busy-mindedness and anxiety associated with their pain. And so they're wondering how you address the biopsychosocial aspects of TMD specifically with your patients.
Well, this is why I highlighted before the importance of a multidisciplinary team and to have involved a health psychologist to be able to to address those issues, because as we know, not only this type of personality, but other ones, they have a tremendous impact on pain. So it's quite important to be able to address the patient in that context, because some of the treatments may have success or not if this is not treated or addressed adequately. And you are welcome. I'm very happy to talk about this topic.
Fantastic, thank you. So our next question, somebody's asking if Botox and other preventative or steroidal medication do not prove to work for migraines, is there anything else providers can try to help patients with managing migraine-related pain?
Well, so far, it is actually quite important, in my opinion, and from the opinions of also of different colleagues who are more expert in headache and migraines. It's quite critical to really discern if there are more pains involved also with the migraine, like a tension type headache, because as I mentioned before, there could be different type of pain disorders happening at the same time. And in that way, something that is frequently overlooked, you could say, is the presence of TMD in patients with migraine. So in this case, the increase of the TMD or the aggravation may trigger the migraine. And from my experience, sometimes this is quite frequent actually, and for some reason is not so well approached. So I think that would be one advice, besides like all the other treatments that for sure like you are aware of based on medications, but change in lifestyles, and also, as I mentioned before, like different types of or related issues to health psychology, and also physical therapy to reduce like peripheral inputs are quite important to manage migraine. And that also includes other pain conditions that are not necessarily in the face, but chronic back pain, for example, any kind of pain can trigger or increase other pain. So it is quite important to assess the patient with the whole approach and not focus only on the migraine, because in that way there are more chances of fail with the treatment, if you may say.
Fantastic, thank you. So another question we've received is that, so do you think that tech neck, so symptoms of sore neck from looking down at cell phones can be a factor in orofacial pain?
Definitely. I think here, I don't know if I mentioned, but a big contributor to orofacial pain disorder is their like neck problems. Again, neck problems can be referred to different parts of the face, like the angle of the mandible or the forehead. So for sure, that has this activity, for instance, but it may be other ones where bad posture is present. It can create orofacial pain through referred pain, but can also be, again, comorbid to orofacial pain conditions like TMD. So then it becomes like more complicated because you are targeting the TMD, but you also have to take into account the neck pain, because the neck pain can increase the TMD. So it's like the main point as before, is a comprehensive assessment of face and neck, or head and neck, but also the rest of the body.
Thank you, Alberto. And another webinar participant is asking, CSF leaks are often misdiagnosed. They're saying that they typically appear as positional headaches and are diagnosed simply by symptoms. Are there other orofacial pain conditions related to postural headaches that are important to note for differential diagnosis?
Yes, it will be more related to the sinus, for example, like sinusitis, or this pain can be also aggravated by bending or moving the head. Importantly, tooth pain can be also sometimes aggravated by posture or moving the head. And it is actually quite common that because of an infection in the tooth, it basically progress to the sinus. So then you have like a disorder more related with the tooth and the sinus itself. There are some type of orofacial pain disorders, very uncommon, like mid-face pain, it's called, that it can be also perhaps aggravated with posture. And perhaps there are more that I'm not remembering now, but yeah, for sure, like it's actually quite important to consider these type of things in the differential diagnosis, and that is also why if the patient doesn't respond to usual treatment sometimes, or even if you are suspicious of different red flags associated with more ominous pathologies, it is quite important to do a very comprehensive assessment, including brain imaging or to referral to the neurologist or appropriate specialist, which would be better again in a multidisciplinary team to be all in the same page.
Fantastic, thank you. And so another user is asking whether you can speak to the use of IV ketamine for confirmed diagnosis of complex regional pain syndrome that stems from the mouth or lower lip post cancer surgery. And this is following trying most of the other suggestions that have been mentioned for neuropathic pain.
Wow, that's an interesting question. So CRPS is actually not very frequent in the face. It has been reported, actually. I think there are a few cases, and we also have to be obviously aware about the diagnosis, but just letting you know, like it's not perhaps as common as in other parts of the body, and I'm not aware of that literature in CRPS, but I have seen more animal studies looking at ketamine infusion. Obviously, this involves like more sophisticated equipment, and it cannot be done in a regular orofacial pain clinic, I will say. And I know that there are also like you can also go with sympathetic blocks of the neuropalatin nerve, or also like more related with the sympathetic ganglion with other type of substances. So definitely, I think ketamine, I read about it, that it can be used, but I'm sorry I could not give you more detailed response for that question, which is actually very interesting.
Thank you, Alberto. So I think we have time for one more question. So this is our last question for the day. Somebody is asking, what would be a therapeutic approach for a case that has bruxism since childhood and it continues later on in adult life, but as an adult, fibromyalgia was also diagnosed. So the main issues are severe bruxism, chronic insomnia, chronic pain, and fatigued.
Yep. Okay. So in childhood, well, basically for bruxism, there are like different strategies. Probably like the most commonly used is like the use of a mouth guard. It's also important to know that the mouth guard basically avoids some of the deleterious consequences of bruxism, or protects the teeth in this case, but is not going to affect the sleep bruxism itself. In fact, there are very few treatments that we know that can affect the frequency or the episodes of sleep bruxism. So in this case, it's also important to know that there are studies showing that bruxism are not associated with increased pain in the face, even though it's kind of common knowledge that it is, but it has been shown that this is not as simple as that. So in this case, I would say like psychological interventions first, like explain what is bruxism, what are the main contributory factors, lifestyle changes, like reduce common causes of clenching or possible grinding at night, like coffee or alcohol, and then followed by a mouth guard to again protect the teeth, but not to decrease the bruxism, would be seen in this type of patient also with fibromyalgia or sleep disorders. But I would say that in this case, bruxism is independent or is likely to be independent of both fibromyalgia and sleep disorders, or sorry, insomnia.
Fantastic. Thanks so much, Alberto. We really appreciate your time and for you lending
welcome.
your expertise today. And I'd like to thank everyone for joining in today. We hope you found this presentation helpful, and we also hope to see you at a future webinar. Thanks, everyone.
Thank you very much.